Good afternoon, everyone. Thank you, Mr. Zanga. Okay, so I'll be taking you through the fetal anomaly scan. So for the fetal anomaly scan, we are going to look at the images that we expect you to produce when you are carrying out your anomaly scan. So the scan is usually performed between 18 and 22 weeks of pregnancy. The anatomy of the fetus should be checked systematically from the head to the toes. So we are going to begin with the assessment of the fetal head. So there are two planes that allow visualization of the cerebral structures relevant to assess the anatomic integrity of the fetal brain. So we have the transventricular plane and we have the transcerebellar plane, but you might also add on the transthalamic plane, which we usually use to measure the biparietal diameter and the head circumference. So to begin with the transventricular plane. So this plane is used to assess the integrity of the ventricles and also the anterior midline structures. So we are going to begin with assessment of the skull bone itself. So the skull bone should be continuous without any defect, and there should be adequate mineralization of the skull bone, so it should be rigid and very echogenic without clear visualization of the internal brain structures and not deformable on probe compression. Then we also assess the shape of the head. So the head should be oval shaped, and there are several abnormal head shapes that you can see that are associated with a lot of different pathologies. So as shown in this image, this is a lemon head shaped, which is associated with spinal bifida. This is a strawberry head shaped, which is associated with trisomy 18, and this is a cloverleaf head shaped, which might be associated with pathologies like thanatophoric skeletal dysplasia. Then to move on into the internal brain structures, what you should see when you are assessing this transventricular plane, you are imaging the head at this level, and your ultrasound probe is this one. So your beam is cutting the head across at this level. So we expect you to see the flux which is dividing the brain, the two hemispheres into two, and then anteriorly an interhemispheric fissure. Then we begin assessment of the posterior horns of the lateral ventricles. So there's an important landmark which will allow you to know the exact position where you are supposed to measure the posterior ventricles. So it is at this level of the parieto-occipital fissure that you are supposed to measure the posterior horns of the lateral ventricles. So we place our caliper from internal to internal. Then our measurement should be less than 1 centimeter. Anything above 1 centimeter, it becomes ventriculomegaly. Then within the posterior horns of the lateral ventricles, we expect you to see the choroid plexus. So that echogenic structure, that's the choroid plexus. And sometimes you might see it with cysts, and it might be associated with chromosomal abnormalities. Then we move on to the anterior part of the head. So from 17 weeks to 37 weeks, whenever you are doing the anomaly scan, we expect you to document this rectangular dark structure, which is the cavum septum pellucidum. So the cavum septum pellucidum will intercept this midline, and absence of the cavum septum pellucidum might be an indication of pathologies like agenesis of the corpus callosum, septo-optic dysplasia, or holoprosencephaly. So when you do not see the cavum septum pellucidum, then you ought to get some additional views like this sagittal view of the fetal head, which will demonstrate whether the corpus callosum is present or not. So the corpus callosum will be this dark structure anterior to the cavum septum pellucidum. So this other image is demonstrating that the corpus callosum is absent and the cavum septum pellucidum is not visualized. There's also a vessel, a branch of the anterior cerebral artery, which is the pericallosal artery, which we see following the course of the corpus callosum. And when it is abnormal, then it will take a different or an abnormal course. So the pericallosal artery is this one, and it follows the course of the corpus callosum, and when it is taking a different course, diverting upwards, then in that case you might be dealing with a case of agenesis of the corpus callosum. Then moving from the transventricular plane that we said we are imaging the uppermost part of the head in axial plane, we might then rotate our probe so that we might be able to see the posterior fossa structures. So the posterior fossa structures that we assess on the transcerebellar plane will include this cerebellum, and then the cisterna magna, and then we can also see the thalamus, and we should also see the cavum septum pellucidum in this plane. So for the cisterna magna, it's a fluid-filled space that we find posterior to the cerebellum. So we take our measurement of the cisterna magna from the outer margins of the cerebellum to the inner margins of the occipital bone, and our measurement should be less than 1 centimeter. Anything above 1 centimeter, it becomes mega cisterna magna, and there shouldn't be any communication between this cisterna magna and the fourth ventricle that lies over there, but is usually not visible when it is normal. So when we see communication, then we begin to suspect pathologies like Dandy Walker. Then we also assess the cerebellum. So the cerebellum should be butterfly shaped. In cases of spinal bifida or Arnold Chiari, it is pulled back because of the meningocele that is within the spine, and it will obliterate this cisterna magna, and it will become banana shaped. In the front of the head, the shape of the head will also appear lemon shaped, like I showed you in the first image. So in this image, we also expect you to see the thalamus, the mid-flux, and also the cavum septum pellucidum anteriorly. So those are the two images that we want you to produce and document always when you are performing the fetal 18 to 22 weeks anomaly scan. Then we move on to the fetal phase. So for assessment of the fetal phase, you are assessing the phase from this plane. So your probe is directed along this path, and these are the structures that we expect you to see and document. So we want to see the forehead. So the shape of the forehead, it shouldn't have any mass, like in cases where there is proboscis. In cases of holoprosencephaly, we see a mass which is a proboscis, and then the forehead shouldn't be flat, like in cases of microcephaly, which is associated with trisomy 21. Then also we shouldn't see any frontal bossing. Then we should also see the nasal bone. So the absence of the nasal bone is a marker of trisomy 21. So in this case, you can see there is no nasal bone. Then we should also be able to see the maxilla, and without any defect on the gap on the maxilla, which might be an indicator of cleft lip or a cleft palate. Then we should also be able to see the mandible, and the size of the mandible should be normal to rule out micrognathia, and it shouldn't be retracted backwards to rule out retrognathia, which are also associated with a lot of syndromes and aneuploidy. Then we should then from this view now, so if you are able to get this view, it's quite easy. You should just try to rotate your probe so that it is now it rotates as 90 degrees in order for you to be able to see the fetal orbits. So we should see both orbits and document them, and we measure the interorbital distance, and we should also see a thin line which is the lens. Then we can also measure the distance between the orbits to rule out hypotaylorism or hypertaylorism. So these are the images that we expect. If there is hypotaylorism, then the interorbital distance becomes small, and if there is hypertaylorism, then the distance becomes wider. Then from this, on this image also we rule out any masses within the orbits. As we can see in this image, there are cataracts. Then we move our probe distally to assess the palate. So in this image we can see the tooth buds and the palate, and we want to rule out any gaps, like in this case where there is a cleft lip and palate. Then we move on to the coronal view, where we assess the fetal upper lips and lower lips, and we should see 2 nostrils and document them. So there are certain pathologies whereby there is a single nostril, and also we rule out any defects on the upper lips of the fetal lips, like in this case where there is a cleft lip. So these are the images that we expect you to get when you are assessing the fetal head and face. So we move on to the fetal heart. So for proper assessment of the fetal heart, we ought to get the 4-chamber view, which is the first view that you should always get, and we ought to get the right ventricular outflow tract, the left ventricular outflow tract, and the 3-vessel tracheal view. So we are going to go through them one by one. So this is the 4-chamber view. So you might begin assessment of the 4-chamber view from the level of the abdomen to assess the position of the heart. So the heart should occupy should be on the left side, or 3/4 of the heart should be more on the left side. So this is the spine, this is the anterior part of the abdomen. So you draw an imaginary line, and you can see that most of the heart, or 3/4 of the heart, is more on the left side. Then the apex should be pointing to the left at an angle of approximately 45 degrees. So that's the angle that we are talking about. Then we move on to assess the ventricles now. So the morphologic left ventricle should be apex forming without anything inside. Then the morphologic right ventricle should have a moderator bend. Then the atrium, the right atrium and the left atrium are almost the same size, so should be the left and the right ventricles. Then within the atriums we see there should be a foramen ovale, which shunts blood from the right atrium to the left atrium. Then we also assess the ventricular septum. We do not want to see any defects on the septum. Then we also have to see the tricuspid valves that are freely moving and the bicuspid valves that are also freely moving. So the position that the tricuspid valve is set should be more apical than the offset of the bicuspid valve. So they shouldn't be at the same level where they offset. So if they are at the same level, there's a possibility that there might be a ventricular septal defect. Then we also have to see the pulmonary veins entering into the left atrium with a aorta below, and the aorta should be more on the left. So there shouldn't be any vessels between this aorta and the pulmonary veins. And then we also assess for any pericardial effusions, and the size of the heart should be approximately 3/4 to the area of the entire thorax. So this is for the 4-chamber view. Then there shouldn't be any aorta and any overriding aorta seen on this 4-chamber view, as we see in tetralogy or Fallot. Then we move on to but on this image now, we can't assess the aorta. Now, neither can we assess the aortic valve, nor can we assess the main pulmonary trunk and the pulmonary valve. So we have to go on and then do the left ventricular outflow tract and the right ventricular outflow tract to assess those regions. So for the left ventricular outflow tract now, on this image, you are assessing this ventricle, and you are assessing the aorta, which is originating from the left ventricle. So there are some pathologies whereby the aorta does not originate from the left ventricle. So we have to produce this image to demonstrate that the aorta is originating from the left ventricle, and then there's an aortic valve over there that should be thin and freely moving to rule out pathologies like aortic stenosis. Then we have to see the continuity of the anterior walls of the aorta and that of the ventricular septum. They should be at the same level. This is another image that we can also use to rule out ventricular septal defects. Then we move on to the right ventricular outflow tract. So this is the right ventricle. This is the main pulmonary trunk. This is the area that we are now assessing because we can't see it on the four-chamber view. So we have to see the main pulmonary trunk originating from the right ventricle this time. And then we have to see in this image, it's a bit more clear. We can see the pulmonary valve, which should be thin and also freely moving. When it becomes thick and the movement is restricted, we begin to suspect pathologies like pulmonary stenosis. Then for you to know whether that is the main pulmonary trunk that is originating from the right ventricle, then it has to divide into the right and left pulmonary arteries. Then, because you are assessing this heart at this level, you can see that the aorta is crossing and they are sort of like at 90 degrees to one another. So in cases whereby there is transposition of great vessels, instead of seeing this aorta in transverse, you then see it parallel to the main pulmonary trunk. Then we also move on to the easiest view to obtain, especially if you are able to obtain the four-chamber view. Just tilt your probe towards the fetal head and you get a three-vessel tracheal view. So for this view now, we are assessing the aorta, the arc of the aorta over there, and the main pulmonary trunk, including the ductus arteriosus, and then the superior vena cava, which will be coming to the heart. So we assess for arrangement of the vessels, we assess for size of the vessels, and we assess for direction of blood flow. So the main pulmonary trunk and the ductus arteriosus, then the aorta second, and then the superior vena cava. So this is the arrangement that we expect to see with no other vessels in between. Then in terms of size, the biggest will be the main pulmonary trunk, followed by the aorta, and then the superior vena cava. Then direction of flow, the direction of flow within this ductus arteriosus and the aorta should be in the same direction. But for the one in the superior vena cava, because it's coming to the heart, should be in the opposite direction. So that's for assessment of the fetal heart. Then we move on to the fetal abdomen. So we started assessing the fetus from the head, and we moved on to the thorax. Now we are at the level of the abdomen, where we measure our abdominal circumference. So for us to get a proper measurement of the abdominal circumference, there are certain structures that we should always see in order for us to say we have correctly measured it. So we want to see a complete rib. We want to see the adrenal gland. We want to see the stomach bubble, and we want to see the umbilical vein as it enters the portal sinus. So these are the structures that we expect you to see for you to measure the abdominal circumference. Then our measurement should also include the skin. Then when the stomach bubble is absent, then and there is polyhydramnios, we wait and see whether it will appear. If it doesn't appear, then we'll begin to suspect upper GI atresia. And if we have a double bubble over there, another dark bubble like this stomach bubble, then we begin to suspect pathologies like jejunal atresia. Then we move on to the level of the umbilicus, where we assess the cord insertion. So from the abdomen, we move distally, then we check if the cord is properly inserted, and we rule out pathologies like gastroschisis over there, and omphalocele. Then we also have to check for condensation at the level of the placenta. Then we move on distally, where we then assess the urinary bladder and the iliac vessels encircling the urinary bladder. So this is the level that we assess the three vessel view. And in cases where there is a single umbilical artery, then it might also be associated with aneuploidy. Then we also assess the fetal kidneys in transverse and in coronal and also in sagittal plane. So to assess for the presence of both kidneys, we have to see both renal arteries, and then in transverse we can then measure the renal pelvis to rule out hydronephrosis. Then we move on to the fetal spine, which we should always assess from the level of the head to the tip of the spine, because this area is the area where most meningocele happen. So we should see an intact skin, and we should also then follow the vertebral bodies, which should be continuous and without any defects, as we see in this image. Then from there we then assess the extremities, so you should assess the femur and measure the diaphysis, excluding the epiphysis. Then you should see the tib fib, the foot, the radius and ulna, the humerus, and also the fetal hands should be documented. Thank you for listening.